speaker is from Mount Sinai. Bert Williams will be speaking on intraoperative residual AI after Ross. Video technique. Bert, thanks for coming.
Good morning, and thank you to Dr. Ozunian and Dr. Adams for the invitation, and of course, Dr. David. I'm honored to be here and speaking in front of you, so thank you very much. Of course, everyone performs perfect operations, and we never have any issues, but every now and then there is some intraoperative residual aortic insufficiency after a Ross procedure. And there's really three different flavors of this type of insufficiency. We can see central, we can see some commissural, and then there's also eccentric, usually from a central origin and moving eccentrically. Jordan briefly touched on that pilot light you see centrally. And so when we think about that, the central, if it's trace, mild, this is benign. Nothing that we worry about. It's almost a staple of the Ross procedure. We don't think much about it. It's when we start seeing commissural or eccentric jets that we start to think more about it. If it's commissural trace and not really traveling into the LVOT, it's just a little pilot light, again, probably benign, something that we'll leave alone. But then if it's more than just mild, we see it traveling deeper into the LVOT, this is something that's concerning and something that we'll want to rectify before leaving the operating room. And the same thing with eccentric. You could almost say that all or any eccentric jet is probably not a good sign, but you can maybe make a argument that if it's trace, it's potentially benign, but this is a judgment call. So let's look at some of these and what they actually look like. So when we talk about central AI, this is really what we mean. So here, this is post-Ross. You can see good leaflet motion. And then, again, just that little pilot light, just a hint of a central regurgitation. Doesn't travel anywhere. There's no directionality to it. It's just central. And you can see it here, just lighting up, very trace in the center there. On the post-discharge or pre-discharge transthoracic, again, you can see it a little bit more here. But, again, not traveling anywhere, low velocity, not a concerning jet, a staple of the Ross procedure. When we talk about, here's another example of central AI. This one may be a little bit more than the first, which was just a little bit of a very hint. You can see it more here, but again, it doesn't go anywhere. It doesn't have any directionality to it. It's just right down the barrel of the LVOT. And again, here on the discharge echo, barely see it at all. So these are benign jets that we don't think about at all. Again, a staple of the procedure. Here's some eccentric aortic regurgitation. And you can see here, it originates centrally, but it's pointing towards the mitral. This is a jet that is concerning and something that we're going to want to address intraoperatively. This is not a jet that we'll be happy to leave the patient with because this is what we think leads to failure. So you can see the pulmonary valve is normal, looks symmetric. And then what we do is we reclamp and we open the graft. I'll touch on that in a minute, but you can see that even with commissural resuspension, it's not like an aortic valve repair. There's no body to the leaflet. It's sub-millimeter thickness. You can't really do any sort of advanced analysis of the valve because there's just no body to it. You can't use a caliper in any real systematic way. And so this becomes a plication based purely on the imaging that you did with the echo. So you have to study this, you take your time, you analyze it, and you find, you make your judgment call based off of the direction of the jet you saw in the echo. And so we typically see that this is a jet directed towards the mitral, so that points us towards the right cusp here. And what you can see is we're using a 6-0 proline and doing a very small plication stitch. And very limited ability to make judgments about how big of a plication because you can't really evaluate the free lengths. You can't really evaluate the effective height. And the best you can probably do at the end is try to bring them together and see if there's a little bit of, if your LV vent can create some suction effect. But it's a little bit of a faith jump here that you have to make in terms of doing it. When we open and then close this, you'll notice that we opened up the graft. We did not open up the anastomosis, the Dacron to autograft. That's a very fragile anastomosis, as Jordan touched on earlier. It's not something we want to do multiple times. So we open the graft or the aorta above. And you can see after repair, now we have lost that eccentricity. It's now that trace central jet, and this is something that we're much happier with. And this is the patient's pre-discharge echocardiogram. You can see that there's barely even a whiff of any sort of regurgitation. Now touching on commissural aortic insufficiency post. So you can see here, this is a jet, and you can see it in the short axis. It has some, I don't know why it froze there, but there's, it's a sufficient jet. It's traveling into the LVOT. It's not just a little sliver. It's something that we want to address. And so this is addressed, again, by assessment of the echo, knowing which commissure. You have to be sure about that. Pretty easy in the short axis, but you can see here there's not really any sort of diastasis at that commissure. This is a deep commissural commissuroplasty suture, and you have to go down to the base of the subcommissural triangle here. And we use aortic pledget to do this, to give some support, because again, the autograft wall is very thin. And we're making sure that we're not interfering with the leaflets. You have to take it deeper into the body, leave a little space away from the leaflet itself, so that once you tie this down, you're not touching the leaflet with your pledgets. And again, I want to emphasize that it's a deep stitch into the subcommissural triangle. It's not just at the very top of the commissure. You really need to close that space in order to bring this down. And again, you'll note that we open the aorta above the anastomosis, not the anastomosis itself. So now, post-commissuroplasty, there is no more residual regurgitation. And the pre-discharge echo, you can see just the central jet. So you can have mixed. You'll see here that we probably underestimated. Now, back in retrospect, it looks very obvious. You can see two separate jets, but for some reason, we really only fixated on the eccentric jet in the center here. And so that led us, here's a transgastric view, and you can see that it really is traveling deeply into it, so multiple reasons why we're concerned about this jet. So we're back in, we reclamped, and we're going to perform the same thing. Again, you'll notice that it's the right commissure, it's the right cusp again, and it's the same situation. You're not really able, oh, you know what, I think it jumped ahead. Well, for time's sake, we did a commissuroplasty and, a central plication of the cusp. We took the clamp back off. I'll make a point of showing that. We did the cusp plication of the right, and then we noticed more definitively that there was a commissural leak here as well. Again, looking back, it seems very obvious that there were two jets, but in the operating room, it was not appreciated. So we reclamped a second time, and this time we went back and did the commissuroplasty. And again, this time it's over near the right, the right non, and you can see it a little bit better how deep we're going into the subcommissural triangle here, and how deep into the body of the sinus. This is not just it's not right by the leaflet, and it's not a high commissuroplasty. This is deep down, and again, we're going to use a pledget here. And for time, I will skip ahead after we see this first stitch go through. So again, now after repair of both jets, we have that trace central jet, and we're much happier with that result. And patient did well afterwards. So the one thing is with these, as I said, that you have to analyze them, and that's how you're going to make your repair decisions, what leaflet you're going to do a plication of. But also give it time. So this is actually from one of our Ross courses. This is our live case. We took the clamp off, and this is what it looked like. And our stomachs all kind of sank. I think the audience was a little bit surprised too. But we waited. This is the worst condition right when you take the clamp off. You have all the pressure of the aortic cannula pushing against a totally empty ventricle that's decompressed, and it's all the pressure on the valve. So this is the worst it's going to look. You wait a few minutes. Everything kind of settles in. It gets better. Still not a great jet. We're not happy with that. This is maybe 5-10 minutes. We're still looking at it and just evaluating where it's coming from and what's happening. And then you wait. This is about 15-20 minutes later. We did not go back. We did not do any sort of repair, and it all settled out. So again, do not make rash decisions to proceed with moving forward with repair. So we talked about how to fix it, but how to avoid it is probably equally important. And it's about respecting symmetry. We've heard this talked about a couple times now, and it's both your radial and your commissural height symmetry. So two ways to do it. One way we used to do it, and one way that we've now been doing more frequently, is we used to typically say we're going to honor the pulmonary valves angles in the the annulus. And so we say it's typically a tricuspid, 120 degrees, and we're going to try to replicate that into the aortic annulus. And if there's any asymmetry, we'll account for that in doing it. Well, more recently, we've been redefining the pulmonary valve angles because there's probably asymmetry that to the eye that we're not really catching. So we use a Corneo cone. Unfortunately, I don't have a video of this. I looked through all our cases. We haven't filmed this portion. But what we're doing is we're marking the 120 degrees on the pulmonary autograft. And then we're going to implant this as opposed to going up and down. It's going to be a little bit more planar implantation if there is asymmetry in these angles. And so I want to talk about the results of this as well quickly. So this is Ismail's cohort of patients. We're looking at 675 procedures and 22 patients underwent autograft repair. That's 3.2%. You can see that 8 of them were for eccentric, 9 for commissural, and then 5 were mixed. In terms of this, there's the mean follow-up is 4 years, ranging from 1 to 12 years, and the follow-up completeness is 100%. You can see that the patients are young, 52, it's primary for aortic stenosis, and the pulmonary valve was functioning well with either trivial trace or absent regurgitation on the preoperative echo in the majority of these cases. And when we look at the patients, so on the left side, these are the patients that underwent autograft repair compared to the whole cohort, and you can see there's not a lot of differences in the pre-Ross valve morphology. So it doesn't seem to be pointing to one type, meaning it's not unicuspid that's the culprit or bicuspid. It seems to happen relatively respective of the whole cohort here. So the 9 patients that had commissural, they underwent commissuroplasty, and the eccentric went central plication, and then the combined received combined techniques. And what related to, or ended up with is 21 out of the 22 patients with no or trace residual aortic regurgitation, and there was that one that was left with moderate AR, and I'll talk about her in a second. So at follow-up afterwards, there's 8 patients that have mild AR, 12 that have none or trace, and then there is 1 patient who's now 7 years out, had a bicuspid pulmonary valve that was used and has moderate regurgitation without any LV dilatation, no symptoms, and has been doing well, so just being monitored at this time, no reintervention. The other patient that I mentioned before that left, that still had moderate afterwards, she was taken back to the operating room 6 days later. Another attempt at repair was made, and still unsuccessful, and at that point, a Bentall procedure was performed. When you look at these patients, the concern obviously with doing plications and commissuroplasties that you might increase the gradient. Well, these are the patients that underwent repair, and this is very representative of Ismail's entire cohort, where we can see that the gradients are very low, single digits, about 4 millimeters of mercury. And it's very safe. 22 patients, only 1 patient had AKI, and no mortality, no reintubation. So even though you're doing 1 or possibly additional multiple cross-clamp, recross-clamping the aorta, it's very safe. So in summary, eccentric or greater than mild residual AI should be addressed. It's not something that you should leave and cross your fingers and hope for the best in the long term. You employ techniques of central plication and commissuroplasty, and this is all based off of your imaging. There's not a lot of intraoperative analysis you can do. And when done, it can be safe, effective, and quite durable. So thank you for your time.
Thanks, Bert. Great job.